I'm very honored to present Professor Murkin. He's currently full Senate Professor of Anesthesia. Professor Murkin has been studying the neurological and cognitive consequences of heart surgery for more than 30 years. He has written more than 125 peer-reviewed papers, 15 book chapters, and 130 scientific abstracts. Between them, I would like to mention some landmark papers concerning the management of PH during adult moderate hypothermic cardiopulmonary bypass, which established alpha-stat management. And his research focused on the use of near-infrared spectroscopy, NIRS, for cerebral oxygenation measurement. This investigation also showed how cerebral emboli and hypoperfusion contribute to the development of postoperative neurological and cognitive impairment following cardiac surgery. Additionally, Professor Murkin has received numerous research awards and has served as an external reviewer and guest editor for numerous medical journals. We are very honored to have you here, and Professor Murkin, the floor is yours.
Thank you very much for that wonderful introduction. And as probably one of the most senior members, not only of this group, but of many other groups, I can give you a bit of an overview of actually 4 decades of neuromonitoring. So I apologize for those of you that may have heard some of these comments before, but we will bring it together and a bit of an overview. And as everyone knows, particularly doing clinical research, it really is, there we go. Thank you so much. It really is a team effort. And so this is some of the group that I've had the real privilege to work with over the years. And I really do have to thank some of our ongoing students. We have an MD PhD program that Marianne Sawalski is involved with, and I think she'll be making a presentation tomorrow, as well as we're also involved with the biophysics lab. So we have a PhD student involved in that, and we've received several grants. And I do have to say I have no other conflicts. We're not currently sponsored by any of the commercial enterprises. So this was, and I again apologize. Most of you have probably seen this slide or something similar to it. But this is back in the 1980s, and to measure cerebral blood flow at this time, we were doing multimodality monitoring with xenon radioisotopes. We were trying to assess not only blood flow, but we wanted to measure metabolic rate. And the way we were doing that was retrograde cannulation of the internal jugular bulb. And of course, you can see that's back in the day. That's actually a Swan-Ganz catheter, which I'm sure some of the junior trainees may not have even seen recently. Of course, we're all using echo now. This also involved, as say, radioisotopes, and it was discontinuous. So we'd take samples, have them analyzed, and then post hoc, we could determine not only what cerebral blood flow was, but what the relevant oxygen consumption was. And it should be pointed out that certainly in the early days of cardiac surgery, with the introduction of cardiopulmonary bypass, it was felt that the pH of 7.4 is some kind of a universal constant. And so to that end, most patients are managed with pH stat, which means that one would accommodate the increased blood gas solubility by adding exogenous carbon dioxide. This is called pH stat, and that was pretty much the standard of care. So when I began my clinical career, there were 2 recently published papers at the time, one from Henriksen. They showed that the highest blood flows they measured using xenon was during cardiopulmonary bypass, during hypothermic bypass. And then the year later, Gouvier, Reeves, and colleagues from Alabama published their paper, which showed the lowest cerebral blood flows during hypothermic cardiopulmonary bypass. And so in the literature, we had these completely divergent results, one showing very, very high blood flows, one showing very, very low blood flows. And of course, there was a lot of controversy. And of course, the short answer was this is the brain. So of course, more blood flow has to be better. So at that point, we actually introduced this concept of retrograde cannulation of the internal jugular bulb, allowed us to sample effluent cerebral venous blood. We could look at oxygen extraction across the brain, and that allowed us to actually measure cerebral oxygen consumption. And this is what we basically showed. First of all, that during hypothermia, as well as under anesthesia, the cerebral oxygen consumption, the metabolic rate, is significantly reduced. And what this means is if one is adding exogenous carbon dioxide, that we're producing a hyperemic situation, so that blood flow is greatly increased, far more than is required for metabolic demand. Whereas with alpha-stat, maintaining the pH at 7.4 at 37 degrees, not adding extra carbon dioxide, allows autoregulation to be preserved, and so blood flow will be driven by metabolic demand rather than artificially increased by the CO2. And at the time, it was some of the first time when all of the issues about cerebral emboli were beginning to appear, and people were doing things such as retinal micrography and demonstrating that we're showering the brain with these microgaseous, microparticulate emboli that were showing up in the retinal circulation. And so our concern was hyperemia increases the potential for delivery of emboli into the brain. Because at the time, this was a fundamental change in management, we had to demonstrate that this had some kind of impact on patients. So we undertook what at the time was the largest study, 300 patients randomized to alpha-stat, pH-stat, and showed that for patients that were on bypass longer than 90 minutes, there was in fact a significant impact on cognitive dysfunction 2 months post-operatively. So we were doing a sequential cognitive testing before 1 week, 3 days to 1 week after the surgery, and at 2 months, and again at 3 years later. So what we're able to show is that there was this significant impact of CO2 management on patient outcomes, and that this was persisting for at least several years post-operatively. And you think about this, cognitive outcomes 2 months post-operatively were influenced by 90 minutes of an increase in PCO2 that measured about 15 millimeters of mercury difference between the two groups of patients. So just a little bit of carbon dioxide at the wrong time can have a profound impact on brain outcomes in our patients after bypass. So this says that subtle changes, in this case a little bit of CO2, in a susceptible patient, what makes you susceptible? Well, the fact that rather than having the lungs acting as a filter, we're now putting blood directly into the systemic circulation, can have a dramatic impact. And the challenge is determining who's susceptible, and that sort of led to all of our interests in neuromonitoring. So this is a picture of our current devices. What we're doing now, this is entirely non-invasive. It's all photon-based, so these are all NIRS, or near-infrared spectroscopy-based systems. And because they're continuous, we can actually look at not only blood flow, but also metabolic rate on a continuous and virtually real-time basis currently. So dramatic changes. The other thing that came out of this initial study was the fact that we actually, because we were able to access the cerebral circulation to measure blood samples, we actually provided, working with INVOS, all of the validation data that allowed them to calibrate the algorithms they were using for their NIRS devices And shortly after we were involved in that, the FDA actually approved the first commercial NIRS device, and that's how we got involved in brain oximetry. Because we're very interested in physiology, we had an algorithm to actually look at changes in the NIRS saturations continuously and used physiologic-based interventions. Number one, altering the CO2, looking at perfusion pressure, looking at cardiac output, pump flows, and things of this nature, and found that we were able to, first of all, impact patient outcomes. So by monitoring and then intervening to try to alter the NIRS numbers, we found that not only was there a trend, this wasn't a large enough study to look at stroke, but our strokes were lower in the INVOS patients, but most importantly, the systemic outcomes. When we looked at major morbidity and mortality in our patients, we found that it was significantly lower in the patients in whom we monitored and treated changes in their brain oxygen saturations. And at the time this was published, it was felt that we hadn't actually done anything extraordinary to these patients. All our management was slight alterations in the mean arterial pressure, small changes in CO2, pump flow rates, et cetera, et cetera. And we found that in this study, there was about an 80% success rate. So when we saw significant decreases in brain sats, about 80% of the time, we were able to influence that. This is 2007. When the paper was presented, again, it was very controversial, a lot of criticisms about it, and mostly people saying things like it's a random number generator. When I see the numbers change, there's nothing we can really do, so we really don't believe these results. As I say, it was physiologically based. This was the algorithm that we presented to show the types of interventions we were taking, and subsequently there were at least 3 separate randomized prospective studies looking at the use of this intervention algorithm. And this one was one of the first ones. This is a single center study, and they showed that they had an 88% success rate. This is a completely different study now. This had again, another 200 patients done in the US. They found there was a 92% success rate. And the last study, again, another 200 patients, 8 different centers, and they found a 97% resolution rate. So again, starting with the fact that, first of all, one really can measure oxygen concentrations in the brain, oxygen saturations in the tissue, and understanding cerebral physiology, one can take steps to influence that. And these studies demonstrate that this can significantly alter the brain sats and return them to normal. We published at the time that this had an impact on systemic outcomes. And again, that was rather controversial. If we're monitoring the brain, what does this have to do with the kidneys? How can monitoring the brain, influencing the brain, have an impact on these other organs? But of course, as the most highly regulated, auto-regulated organ, if the brain is desaturating, then that you have to ask the question, what's it like for perfusion for the guts, the kidneys, and all of the other organs? So if the brain's in trouble, chances are the other organs are in trouble as well. The converse doesn't hold. If your brain sats are good, it doesn't imply all the other organs are good, but it does imply if the brain sats are going down, chances are all of the organs are being relatively ischemic. So intervening helps the brain, helps the other organs. Very fortunately, there's been a number of other studies now that have showed something very similar. And this was a large study done from the group in Boston. They looked at 450 patients, and they found an 18% incidence of adverse outcomes associated with hypoperfusion that resulted in a decrease in brain saturations, basically the same type of phenomenon that we had demonstrated. So it seems to corroborate the observations that we'd made. We also looked at the fact then that we find that the brain saturations are responsive then to physiologic interventions. And the big question is, does preserving this, if you avoid these desaturations, does that result in improved outcomes? And that's still an open question. And there were several trials that were attempting to address this that have not yet been completed. So where are we in the future then? Well, as mentioned, we're now looking at completely non-invasive devices. And one of the newer concepts is the fact that we know that there are a number of limitations to the current tissue oximetry devices. In that, depending on what one uses to raise the perfusion pressure, if the patient's a bit hypotensive, this can cause cutaneous extracerebral vasoconstriction, and this can impact the actual saturation measurements that are read. So there is some bleed through, as it were, of extracerebral tissue. And it's obviously a highly regional. You're looking about 1 sonometer of tissue, it's been estimated, is what's being actually interrogated, which means that it's entirely possible to miss areas, again, of ischemia within the brain. And there's been several studies that have said, gee, we had brain oximetry on, there were no changes, a patient had a stroke. The problem is that most of the time what we're really looking at is areas of the frontal cortex. So yes, it's entirely possible to miss other areas of the brain that may be becoming ischemic. One of the newer phenomenon that's come out is looking at the integrity of cerebral autoregulation. And as you know, cerebral autoregulation means the ability to provide a continuous substrate delivery governed by regional metabolic rate over a wide range of perfusion pressures, classically felt to be between 50 and 150 millimeters mercury. And what this really tells you, of course, is that the brain is actively vasodilating or vasoconstricting in order to provide sufficient substrate delivery. And again, CO2 will interrupt that ability to autoregulate, but so are other conditions, including atherosclerosis, can impact this type of autoregulatory abilities of the brain. And so what has been a newer area of investigation is the ability to look at the correlation between changes in cerebral blood flow. Now, whether this is measured by transcranial Doppler as one measure, whether it's using the near-infrared spectroscopy as one index of cerebral blood flow, and looking at the correlation between changes in perfusion pressure. So if there's no correlation between changes in pressure over a clinically relevant range and the brain saturations or the TCD flow rates, then you say autoregulation is intact. But as soon as we start to see that changes in perfusion pressure will influence the transcranial Doppler signal or will influence the brain saturations, then it tells you at that pressure, the patient is not autoregulating. They have pressure passive flow. If pressure goes up, flow goes up. If it goes down, it goes down. So it's a way of looking then in real time at the autoregulatory integrity of the brain's microcirculation. We've done some studies now. This was with a device from an Israeli group. And this was a way of looking at not only brain saturation, so it was a NIRS device, but it also had incorporated a Doppler signal. And the idea is that the Doppler signal will cause perturbations in the NIRS signal. And those perturbations can be quantified to give you an index of cerebral blood flow. So you can determine whether flow is changing, whether it's increasing or decreasing. So it was a way of looking at both flow and metabolism in real time. What this was showing, this slide demonstrates two patients. The one on the bottom of that slide says that there's no autoregulation. So as you look, the index on the bottom is perfusion pressure. So in that case, as perfusion pressure goes up, blood flow and cerebral oximetry values go up. As it goes down, they go down. So that's a patient that is not autoregulating. On the top graph shows the lower limit of autoregulation in a particular patient. And as we said before, the concept, the clinically, the idea that most of us have is that the patient will autoregulate down to about 50 millimeters of mercury mean arterial pressure. Well, the patient on the top graph, his lower limit of autoregulation, I think, is about 65 or 70 millimeters of mercury, because we see when the pressure is above 70, there's no relationship between the flow, the NIRS values and the perfusion pressure. But when it falls below that point, it becomes pressure passive. So we can identify the lower limit of autoregulation for each individual patient. And what we demonstrated was that about 20% of patients, adult patients having cardiac surgery, had no definable autoregulation. Again, this was very controversial at the time, and the group in Boston then did a somewhat similar study. And what they were able to show is, once again, they found in their study of 450 patients that about 20% of patients, adult patients having heart surgery, did not autoregulate. And that in those patients, there was a significant correlation. If you have impaired autoregulation, your likelihood of having an adverse CNS event was significantly increased. So suggesting that these are, in fact, clinically important distinctions and clinically important patients to identify, as this may be a harbinger of an adverse neurological outcome. One of the incentives, one of the primary motivators for the development of NIRS was not actually to look at tissue oxygen saturation, but rather to actually see if we can measure cytochrome C oxidase. Because as you probably recall, cytochrome C oxidase is the final link in the electron transport chain. So cytochrome C oxidase, the redox state of the cytochrome C, is a key determinant of the status of oxidative metabolism. And if your cytochrome C is in its stable value, it implies that oxidative metabolism is occurring as it should. And that if you think about it, all of our monitoring and all of our goals are really directed. The reason we select a blood pressure, a cardiac output, a hematocrit concentration, all of these parameters are ultimately trying to ensure that we have adequate substrate delivery. And we don't actually know if we've got adequate substrate delivery until the patient wakes up and we look and see all the organs are functioning normally. If in real time we can look at cytochrome C oxidase, it'll tell us that at least in that region of tissue that's being examined, that independent of the hemoglobin, the blood pressure, all of these parameters, if cytochrome C is stable, it suggests that you're having adequate delivery of substrate. So how do we do this non-invasively? Well, most of the commercial devices are really looking at a limited number of wavelengths that allows you to look at oxygenated and deoxygenated hemoglobin. But hemoglobin is such a strong chromophore that it absorbs a lot of the signal, and the cytochrome C signal is buried. That's the green line within these is overlain by the signal from hemoglobin. And the use of broadband NIRS, which is basically looking at a broad spectrum of NIRS signals. It's basically white light, but it's broken down into all of the different wavelengths. And by, in this case, the device we're using has 264 different wavelengths that are being analyzed, and that allows one to extract out the cytochrome C signal, and therefore we can use this to assess the adequacy of substrate delivery. The other technique is called diffuse correlation spectroscopy. And this is the extreme other end. Rather than using a large number of wavelengths, instead here we use a very specific wavelength that is laser generated. And the small motion of the red blood cells is enough to provide some degree of perturbation of the returning signal that can be analyzed, and again, to give a correlation, to demonstrate whether a flow is remaining stable, increasing, or decreasing. So we can look at relative change in cerebral blood flow in real time, continuously, and non-invasively. And that's what the far graph is demonstrating: normal, slow, and fast blood flow in that particular region of brain. So the first time then we can actually look in real time at both flow and metabolism in the brain of patients during surgeries, and try to determine the impact of various interventions on cerebral perfusion. And so this device allows us to integrate these various signals, and we're getting a readout in real time that tells us what's happening with regional cerebral blood flow. So this is one of the last slides to show, but what it's demonstrating here, this is just the induction of anesthesia. So we give drugs. We know that causes both a reduction in oxygen consumption. We can get an isoelectric EEG with a large bolus of propofol. And what we're showing here is that cerebral blood flow is going down, and at the same time, the cytochrome C oxidase is following in parallel. So there's coupling then between the flow and the metabolic rate. So autoregulation is preserved during this time. One of the interesting phenomenon that's come out of this has been this phenomenon, which shows that in some patients there's a difference. That what we see on the bottom is the blood flow, and what we see on top is the change in the cytochrome C oxidase. And so although the delivery has fallen, there's a lag in the reduction in CCO, which suggests this may be some kind of ischemic reserve. We don't know if this is a real phenomenon. We've seen this in a couple of patients, but it suggests that there may be some intrinsic, what's the word, protective mechanisms in patients that allows them to tolerate some index of hypoperfusion for a limited period of time. And this is one of our areas of ongoing investigation. And I think what we're doing then, sort of as a cascade of patient monitoring, is we always, of course, are looking at our patients. We monitor the vital signs. We're now introducing, for the last number of decades, pulse oximetry, so we can look at tissue delivery of substrate and the oxygen saturation in those tissues. We're monitoring the hemodynamics and looking at cerebral and tissue oxygenation. And won't digress into our studies on tissue perfusion during bypass, but there's a number of applications now of these types of devices to enable us to look at both flow and metabolic demands in a variety of tissues in real time. And all of this is telling us that we have adequate substrate delivery and therefore are preserving oxidative metabolism. And I think that's where we are currently. So thank you very much for your attention.
Thank you very much, Professor Murkin, for this amazing talk. Cardiac surgery patients are very complicated and challenging. We have to deal with issues like impaired autoregulation, impaired coagulation, impaired microcirculation. That's why our need for monitoring is very demanding and upgraded in order to reveal at early stage the impairment and prevent further damage. And in this point, our action can influence outcome because we have the information from the monitor and we intervene. And I would like to mention the first time that I heard you speaking live in presence. It was in Paris, 2008. Together with the cardiac surgeons later. It was amazing. For me, it was a presentation of this landmark paper. It's one of my favorite papers, the anesthesia analgesia monitoring brain, because it made a lot of sense and it changed the way that we are dealing with monitoring devices in the operating room. So are there any questions or comments from the floor?
Thank you very much. I just like to make a comment that I've always found the fact that patients can tolerate cardiopulmonary bypass a real testimonial to the integrity and the viability, I guess, of the human organism. But if you think about it, for 40, however aged the patient is, 70-year-old patients who've maintained a CO2 within a very tight range for 70 years, who've had a hemoglobin within a very tight range for 70 years, pulsatile perfusion. I thought it was interesting in the previous discussion about pulsatility. And suddenly we put them on normothermic or hypothermic bypass. They become anemic. We influence all of these factors, and most of the patients survive grossly. Most of them do well. But again, we're no longer interested in just having the patient survive the operation, but we're trying to improve outcomes and minimize some of the attendant consequences of these, very challenging perturbations to homeostasis. And I think what this really certainly demonstrates to me is, as we say, there are times at which a patient is particularly susceptible. Mm-hmm. And unless we're monitoring, unless we're anticipating this, we may not recognize that. And you may have a slight combination of a bit of hypotension, a bit of hyperventilation. So CO2 goes down and the patient's a bit anemic. and when those three things happen to coincide, we can have a significant end organ injury for something that's a relatively transient phenomenon, and yet in a susceptible patient can produce adverse outcomes. And it's only by these types of investigations and really examining what we're doing critically and trying to get some feedback from the tissues, from the organs that we're concerned about, that we can identify these times at risk and then try to intervene. So I think, again, it's very interesting times. And certainly in my career, to have moved from using radiation and very invasive cannulations to being able to do this all now non-invasively, just shining a light, is quite remarkable. So I think we have a lot more information to derive. And yeah, thank you all for your attention.
Professor Murkin, we're grateful for your presence here in our meeting and for being a lasting inspiration for us. Thank you very much.